Good afternoon, everyone. Thank you so much for joining today. We'll just give another minute or so for some more folks to join, and then we'll get started. All right, so we will go ahead and begin. Good afternoon, everyone, and welcome to today's webinar, which is being hosted by Hepi United and the Coalition Against Hepatitis for People of African Origin, or CHIPO. My name is Beatrice Zovich, and I'm a Public Health Program Manager at the Hepatitis B Foundation and the coordinator for CHIPO. Today's webinar will focus on addressing myths and misconceptions about hepatitis B among African immigrant communities around the United States. Our panelists will share about their work in African communities in general, with hepatitis B in particular, and methods that they have found for successfully dispelling persistent myths about hepatitis B prevalence, transmission, prevention, severity, and treatment. They will also discuss how some of these misconceptions can contribute to the serious stigma and discrimination experienced by many people living with hepatitis B in these and many other communities, and ideas for how to counter misinformation and construct a new narrative that is person-centered and that can create a new dialogue and accurate information about hepatitis B, thus encouraging more screening, prevention, and management for the virus. Next slide, please. So before we get started, I just wanted to share a little bit about joining and participating in today's webinar. So I'd just like to remind participants that during the webinar today, all audience members are going to be muted. We encourage you to use the chat feature to let us know who you are and where you're joining from. And if you have any technical challenges, please indicate your issue using the chat box and we will address it as soon as possible. And if at any time during the presentation you have questions, which we hope you do, you can enter them into the Q&A box so that we can better keep track of them. Questions will be addressed by the speakers at the conclusion of the presentation. This session is also being recorded and slide presentations will be shared following the webinar. Okay. So just to give a quick overview of Hepi United and CHIPO. So Hepi United is a national coalition that is dedicated to reducing the health disparities that are associated with hepatitis B by increasing awareness, screening, vaccination, and linkage to care in high-risk communities around the United States. And the coalition has about 50 members in 30 states around the country and is continually growing. Next slide, please. And then just a little bit about CHIPO. So the Coalition Against Hepatitis for People of African Origin is a national community coalition that was founded and is led by the Hepatitis B Foundation and is comprised of organizations and individuals who are interested in addressing the high rates of hepatitis B among African communities in the US. CHIPO serves as a forum for sharing information and best practices about improving the national capacity to increase hepatitis awareness, testing, vaccination, and treatment among highly affected African communities around the country. Next slide, please. Thank you. So to get started, we are very excited today to be joined by a panel of distinguished speakers. First up, we have Dr. Olorunseun Ogunwobi, who is the director at Hunter College Center for Cancer Health Disparities Research in New York. And he is also the co-chair of the New York City chapter of CHIPO. So very excited to have him joining. And our two other distinguished guests include Dr. Ganyat Sarumi Disu, who is the CEO of the African Health Coalition in Chicago, and Mrs. Oluwatoyin Adedokan, who is a community health worker and educator also from the African Health Coalition in Chicago, and they will be sharing with us a joint presentation today. So we're very excited to welcome these speakers, and without further ado, we will begin with Dr. Ogunwobi. So if you would like to go ahead and share your screen, and we'll get started. Thank you so much.
Good afternoon, everyone. I'm very pleased to be with you all this afternoon. And I thank CHIPO National Coalition for inviting me to participate on this panel. I'm coming from the Hunter College Center for Cancer Health Disparities Research, and I will, in the beginning, just provide some very brief overview of the topic, and then I'll talk a little bit about some of the work that my group has done, and then at the end of the presentation, I'll comment on some of what I've learned in regards to myths and misconceptions about hepatitis B among community. So let me just start by pointing out something on this first slide, and that's something we all know, that hepatitis B virus is very highly prevalent in sub-Saharan Africa. You can see the darkly shaded portions of West Africa, some parts of Central Africa as well, but also you can see that Southeast Asia is another area of high prevalence. On the next slide, I do want to show what happens at the end stage. So chronic hepatitis B infection ultimately will lead to liver cancer. And you can see here in the United States that the rate of liver cancer is increasing both in men and women. In fact, mortality has gone up by 43% in the last period that was investigated. So this is a problem. High prevalence is leading to high end-stage liver disease, such as liver cancer. Now, what's important to note on this next slide is the most common form of liver cancer is hepatocellular carcinoma, but given that chronic hepatitis B virus infection is a major cause of this end-stage liver disease, and the fact that hepatitis B virus can be prevented by vaccination means that a large amount of liver cancer can actually be prevented by means of vaccination for hepatitis B virus. On this slide, I just want to draw your attention to the section that's labeled D. So that section is presenting information on the rates of hepatitis B virus infection. The green line that's at the top, that's Asians. So very high rate of hepatitis B virus infection in Asians. But the next one, the red line with the square boxes, that's blacks, non-Hispanic blacks. So you can see that there's disparities, Asians number one, blacks number two, but then the blue line is non-Hispanic whites, and then the purple line is Hispanic. So you see the disparities in hepatitis B virus infection ultimately then leads to disparities in end-stage liver disease, such as liver cancer. On this slide, where do African immigrants mostly live? Well, the most popular states where they live, New York, Maryland. You can see that on the slide, Texas as well, darkly shaded there. But it's interesting that 4 counties particularly stand out: Montgomery County, Maryland, Bronx County, New York, Prince George's County, Maryland, and Hennepin County, Minnesota. And I was interested to find out that just in those 4 counties, there are about 12% of all of the immigrants from Africa in the US. So that's an interesting little fact I wanted to share. Let me just go back. What I want to say on this particular slide is that immigration from Africa to the United States has steadily increased over the years. And I work in New York City. The most concentrated area is in Brooklyn. But at the bottom of this slide, notice that overall prevalence among all New York City residents is between 2 and 3%, and those that are definitively diagnosed with hepatitis B virus infection between 1 and 2%. But it's estimated that overall prevalence among immigrants in New York City is between 6 and 7%. So you can see the disparities there. And that's why we're having this panel. And that disparity, again, as I mentioned, will likely translate into disparities in end-stage liver disease, which is liver cancer. And that's particularly concerning because at that point now, you're talking of, possibility of death, which is the outcome that we all want to avoid. So what have I done, myself and my group at the Hunter College Center for Cancer Health Disparities Research? We have worked in this area, particularly looking at screening and vaccination and factors that may be affecting screening and vaccination rates among African immigrants in the United States. In the study that we did, a pilot study, we assessed hepatitis B virus screening and vaccination prevalence. We assessed factors that predict these behaviors, and we looked at potential factors or implications for public health interventions. It was a survey study, a cross-sectional survey. We ended up studying 71 participants using a tool that comprises 25 questions and relatively easy to administer in about 15 to 20 minutes. Using that tool, we were able to assess knowledge of hepatitis B virus status of family members, knowledge of hepatitis B virus transmission, social demographic factors, and immigration-related factors. And we did statistical analysis using a variety of methodologies, univariate analysis, chi-square testing, student testing, and so forth. What did we find? One of our main findings was that screening and vaccination rates are generally low. Not surprisingly, many others have found the same thing. The other thing we found is that 2/3 of participants reported having never received any recommendation from their doctors to be screened or to be vaccinated. The other thing, and I will talk a little bit more about this when I talk about the myths and misconceptions, is overall knowledge of how hepatitis B virus is transmitted is generally low among the group that we studied. Interestingly, you may find this interesting, but I believe it's logical. We found that marriage and having a college degree were predictors for hepatitis B virus screening. And then we found that health insurance was a sole predictor for hepatitis B virus vaccination. Again, it was a relatively small sample size, so we do like to mention the limitations of that study. But we learned some important things that continue to underscore the importance of surveillance, vaccination, screening, treatment, and also intervention at the policy level. So back to the main topic of the day. What are some of the common myths and misconceptions? So I've decided to mention them, but then talk about what should be the antidote to them, what we really need to let our community members know about some of these things. So one common one is that there's no treatment. We need to let our community members know that while it's true that there's no cure right now for hepatitis B infection, there is treatment. It's a manageable disease that can be treated. The other misconception is that it's hereditary or genetic. So somebody has it, as of necessity, they will pass it on to their offspring. We need to let them know that it's not hereditary or genetic. Now, that's different than mother-to-child transmission, which happens during the birthing process, where we can explain to them that happens because of contact of the newborn with the body fluids of the mother. It's not because the mother genetically passed it on to the child. So that's something we can address within our communities. Another common misconception is that casual contact, like shaking hands, hugging, kissing on the cheek, sharing meals, sharing water bottles, that those kinds of things will lead to transmission of the disease. We can address this also in our community by making it clear that casual contact will not cause transmission. Instead, it's intimate contact, touching body fluids. Good example being through unprotected sex or blood transfusions and things of that nature. Another common misconception is in regards to breastfeeding. But we can correct this because there's some nuances there. Breastfeeding is generally safe, and children do have a lot of benefits from breastfeeding. What's important is that, if the mother is infected, then the baby needs to be vaccinated. That offers some protection, but also the mother should be treated. That certainly also offers protection. And of course, they need to be aware that if there is, cracked nipples or bleeding nipples, then that's a particularly risky situation. But a blanket rule that breastfeeding is unsafe, that can be corrected within our communities. And again, related to the first misconception I mentioned is the idea that, it's untreatable, it's fatal. I picked up this piece of information that in India, for example, there are up to 20 to 40 million people that are living with the disease. So it's not inevitably fatal. So because that's related to the concern about stigmatization. Was that a warning to me? So let's go on to the next one, where there's also a misconception that being vaccinated doesn't prevent infection. So we need to correct that. And then some even have the misconception that, if they have it, can they get married or have kids? Of course they can. We should correct that as well. And also the misconception that they can pick it up from insect bites like mosquitoes. That's not true. On this slide, I just want to mention a few more things. Many of the misconceptions are related to these factors. Religious beliefs, some people believe that everything's caused by God. And so they don't seek treatment, or they just think if they pray, that solves the problem. Many of the other misconceptions are related to cultural beliefs or cultural norms. People feel that if they have a health problem, they need to, they don't want to go to Western medical practitioners. They want to go to traditional practitioners that often do not provide the same level of treatment, which we know to be effective from Western medicine. And then all of us in our lived experience see how oftentimes within the African immigrant culture, there is a focus on treatment rather than prevention. And so that may be the cause for the lower uptake of vaccination. And as I mentioned from the study that we did, there is, in some cases, total lack of knowledge, and in many other cases, partial lack of knowledge. So, and we can address that. And finally, I just want to talk about stigmatization. So many infectious diseases, such as hepatitis B virus and HIV and many others, have been stigmatized, and that even affects the ability of people to engage in preventative practices, but certainly in practices that are related to accessing care and receiving treatment. So I'll stop there and look forward to hearing from my colleagues. Just one final point on my slide: the role of superstitious beliefs. People thinking that maybe they caught it from some person that hates them and did some spiritistic attack on them and those kinds of things. These are my collaborators, and we've received funding for some of our work from the National Cancer Institute. Thank you.
Thank you so much, Dr. Ogunwobi. We really appreciate those that perspective and learning about a lot of those specific myths and misconceptions, and we can definitely discuss those a bit more. But now we look forward to hearing from Dr. Disu and Mrs. Adedokan, who are joining us from Chicago, and have a lot to share about community experience and further speaking about some misconceptions that are prevalent in the community. So I hand it off to both of you. Thank you so much.
Thank you very much. Thanks to Dr. Ogunwobi. Thank you very much, Doctor, for that great presentation. So our presentation today is on the same thing that Dr. Ogunwobi talked about, And two of us will be presenting, myself and Mrs. Oluwatoyin Adedokun, on the same subject. Can you change this slide, please? So I do have a food for thought here. Talking about vaccine, it is very important for people to know that vaccine do work. I got vaccinated as a kid. As a result, I'm now starting to have gray hair and my hair is bald. My balding got so bad, I had to cover my head. I have gained weight and also have some wrinkles because of vaccine. I have started aging instead of dying as a baby. So that is just to say that vaccine do work. Maybe I should have been dead if I was not vaccinated, but I'm still here, growing, gaining weight, having wrinkles, and getting bald. Thank you. Next slide, please. On this slide, we're going to tell you a little about our organization. And we started this organization just because of what is going on in the African immigrant community. What happened at that time, it was 20 years ago. And what happened at that time was there was a lady that came up to me, complained of headache and blood vision. So as a nurse, I took her blood pressure and the blood pressure was really high. So I had to send her to the emergency room. From there, I started talking to a lot of people and I realized that most of our African immigrants, they either don't have insurance or they don't know the importance of primary care, or they get medications and they just don't use it. So because of that, in 2019, we established African Health Coalition, which is located at 2019 on the south side of Chicago. Due to the recognition that high rates of chronic disease in the African immigrant communities was a result of unaddressed and under-addressed chronic health conditions such as hypertension, diabetes, hepatitis B diseases, and also some social determinants of health like discrimination, powerlessness. We don't have the power. We don't know what to do. African immigrants' culture, the beliefs, the practices, and then the ethnic background. Also, immigration status affects too. And then there's a lot of problem navigating the healthcare system in America. Also, we decided that we're going to have a mission. Our mission is to change the African immigrant mindset and the faith community culture towards health and health-related issues in order to be able to address these issues that contribute to limiting African immigrants' access to better health and lifestyle resources. And those services are the services that we provide in the cultural barrier, the attitude of the healthcare services, access to basic health, refer them to basic health, talk to people, talk to African immigrants about health education, the importance of screening, especially screening with hepatitis B that can be prevented or be treated, and then network, send African immigrants who are screened for care, tell them the importance of how to make sure that they control their chronic disease, either blood pressure, hepatitis B, diabetes, just making sure that they are aware, increasing awareness, and also increasing the education in the community. Next slide, please. So where do we get our population? In most cases, the populations we get from the faith-based organization, like the mosques. Just like I said earlier, I started at the mosque, and we started at just one mosque. Now we have probably maybe about 5 mosques that we're working with. Also, we go to the churches. So we have about 3 or 4 churches that we work, and we go there from here to there, talking to them about health, talking to them about the importance of health and prevention, and also some social organizations. Also businesses, we go to the stores, we go to the shops, the salons. We can drop off some pamphlets there. So other times we just go to the salon and have people cutting their hair or having their hair done, and we talk to them there because we know where the African immigrants are. So we go there where they are to meet their needs. Next slide, please. So hepatitis B, now this is a picture of when we had our hepatitis education. We had an education. We also had the screening. We usually have the education in the places that we go. And like I said, some of these places are the churches or the mosques. This particular one, we had it at the church. And this is a very recent one. Letting people know, letting the African immigrant know that hepatitis B is a silent killer disease and it's life-threatening. And then we increase the awareness, talking about the education. We continuously reinforce the education. We try as much as possible to reduce the stigma. Just like the presenter before me said, there is a lot of stigma out there that people feel. And if we don't continue to exercise this education, reinforce this education, and letting people know that these stigmas are nothing but something that people just talk about. There's no facts on that. So to reduce those stigmas, we provide hepatitis B education. We also support those people that are living with hepatitis. I remember there's someone that we screened a couple of years ago that this person was just devastated hearing that he's positive. Even though I don't get the result, he don't send me the result, but he came up to me to talk to me about it. And what did we have to do? We sat down, we talked to her. We mentioned to her the importance of, just making sure that he follows up, and then letting the family all be screened, which is something that is very hard. And then we also do a follow-up. And we also refer for care too. If they do need to be treated, we refer them to be treated. If they need to be vaccinated, we refer them for vaccination. We use a whole lot of FQHC clinic, and we also use some government clinic or some clinics in the surroundings that can help to vaccinate them. Sometimes we also do have some vaccination sites ourselves that we go. We sometimes go to the mosque to have a vaccination site there, and sometimes to the churches to have a vaccination site there, just to make sure that African immigrants' health population are vaccinated and taken care of and connected to care. Next slide, please. So this is about the myths and misconception of African immigrants of health. Now, the definition of health, according to World Health Organization, is that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Now, in African immigrant community, that is opposite. In African immigrant communities, you are sick only when you are seriously sick. You cannot get off the bed. If you can get off the bed, you are not sick. There's nothing wrong with you. If you are able to eat and you are able to dine and you are able to take your shower, then get up, go on. So because of that, primary care is a waste of time. We don't want to, African immigrants don't want to do that. In most cases, when they have a primary care, when they have to go for primary care, they say to themselves, you know what, why do I need to go there? I'm not sick, I don't need to do all that. And also, bad health is punishment from God sometimes, because religion is a very important thing in the African immigrant community. The faith is very strong. And when anything happens, in most cases, one of the places that African immigrants will run to is to the church, or to the pastor, or to the imam, or they will start fasting and praying, thinking and making that all this is going to eradicate that disease instead of following up with health. So in most cases, when things happen, they don't trust their provider as much as they trust their clergyman, either the pastor or the imam. In most cases, they go to them. Now, when you also talk about screening, they would rather not know about the disease. They don't want to seek any diagnosis. They resist treatment. Now, one of the things is that in African immigrant community, if you tell somebody that they have hepatitis, to them, it's a big stigma. They can get seriously sick about it. They can start thinking about that, and that can put down their immunity. I remember a couple of years ago, someone that was diagnosed with cancer. And this person said, The reason why she got sick is because they diagnosed her with this cancer. Before then, she wasn't sick at all. Another person that went to the dentist, and the dentist said, you know, you have a cavity there, we have to take it off. They took it off, and the complaint is, you know, I don't have a teeth now just because I went to the dentist. But they have forgotten that if you had done what you're supposed to do, if you have cleaned that teeth very well, if you have been screened as soon as possible or earlier, probably maybe this would not happen. Next slide, please. So this slide is about myths and misconceptions, talking about exactly the reason why we are here today. Some people feel that this hepatitis B is contacted through mosquito bites. I've heard that a couple of times. It is just because I was bitten by a mosquito. That's why I heard this. It is not by mosquito bites at all. No, mosquito bites does not take that hepatitis B and give it to you. It is not common in the African immigrant community. Yes, it is common in the African immigrant communities, and we continue to pass it from one person to another because in African immigrant communities, we do not believe in primary health care. We do not follow up when we're supposed to. Is the same as yellow fever? No. Hepatitis B is different. It's not the same as yellow fever. Yellow fever is different. And one of the reasons why Africans, immigrants, will probably say this is because when there is hepatitis B, when you first contact hepatitis B, especially in the acute stage, people might have yellowish of their eyes. And I believe that's one of the reasons why they attribute that with hepatitis B. So it is very important for people to know that chronic hepatitis B is one of the worst things that we're talking about. And with that one, there is hardly, in most cases, no symptoms. By the time they get the symptoms is probably worse. But when it's in the acute stage, yes, they can have the yellowish of the eyes. And that is when they probably need to check it out. It can be cured by prayer and supplication, fasting, traditional healer. As a Muslim, I am not going to dispute that. At the same token, what I'm going to say about that is that prayer helps, but following up with the physician, making sure that people are screened, they are tested, they go ahead and get their vaccination if they are not immune. If they are positive, to go on and follow up with the physician for treatment is very, very important. Now, it can't transmit through hand shaking and coughing, contact, sharing, eating utensils. No, it cannot. It can only be transmitted, just like the previous speaker said, it can only be transmitted through blood. And that's the only way that it can be transmitted, either by sexual intercourse or things like that, not by contact, just merely contact. No, it cannot. Now, people can transmit it by sharing needles if they do share some needles, or when they go for tattoo, because that is blood. But just merely contact, no, it cannot. Some people also believe that when they have hepatitis B, it is a cause from their enemy. Somebody just don't like me. They just put a curse on me. This is the person that makes me have hepatitis B. And that is why I am sick right now. We've also heard that some people decided that they will not be eating protein, or they should not eat protein if they have hepatitis B. Now, in the chronic disease, if they do have a chronic disease and it's towards the time that, you know, it has affected the liver, or maybe that's something that might be thought about. But merely not eating protein because somebody have hepatitis B or somebody is positive with hepatitis B is not something that should be carried on at all. Cannot be pregnant if positive. This is another myth that we need to get out there and let people know that you can be pregnant, you can also have a child, you can be married with hepatitis B, you can be treated with hepatitis B, and you can live your life just like any other person, even if you are hepatitis B positive. The only thing that you probably need to do is to follow up with your physician, probably like every 3 to 6 months, just as your physician decides to take care of you. Just follow up and make sure if you do need to take medication, take your medication. Another myth is that they must have to isolate themselves if positive. No, people don't need to isolate each of themselves for being positive for hepatitis B. And one of the reasons why people feel that they need to do that is because of all these stigmas and all these myths. So we continue to reinforce these among African immigrant community that we do serve. Next slide, please. So on this slide here, I just want to let you know the impact of hepatitis B, or the impact as hepatitis B has had in our community. Couple of years ago, actually 2019 to be exact, we had a 55-year-old guy who died of hepatitis B in Nigeria. He came here to the United States to visit his sister. And he was sick at the time, and the sister was asking him what was wrong. But he decided to go back home right away. He refused to go to the doctor here. He said, I need to go back home. I'm going to go and take care of myself there. What is he going to take care of himself with? We have no idea. But he went back home, and his sister is a registered nurse. He went back home. Shortly after he got home, he got seriously sick, was admitted to the hospital. Later on, the sister found out that he had hepatitis B. And by the time that the sister found out, he had cancer of the liver. So we call around to find out here if there is any help that can be done. The organization that we were with, they try as much as possible to help us to connect him to care in Nigeria. But, unfortunately, we lost him. There was another case of a community member that died in 2019. This guy knew he had the disease. He kept it from his family. He even kept it from his wife. They did not know. He got sick. When he got sick, it was very serious. He ended up dying. It was too late. The treatment could not make it at that time. Now, one of the ones that really is really painful is the 32-year-old that died from liver cancer. Actually, she did not know that she had a liver cancer. She was born and bred in Nigeria. She came here, I believe, when she was probably maybe 19 or something like that, but she died too. So we lost 3 people in 2019. This is telling you that this hepatitis B is serious. We need to get out there. There's much work, more work to be done in order to continue to increase awareness, increase the education in the community, making sure that all these myths and misconceptions are talked about and people know exactly what the facts are and they continue to follow what the fact is instead of the misconception. Next slide, please. So what are the ways that we have been addressing this myth and the misconception? In the African immigrant community, you have to be a very good listener. You cannot argue because there is a lot of incomplete knowledge. Some people feel that they know everything about hepatitis B. Before you sit them down, they're telling you, oh, I know what it is, and they're trying to code it for you too. So you have to be a good listener. You have to be able to build relationship. So going from one mass to another, going from one church to another, we want to make sure that when we go there, we just don't show up when it's time to screen. We just don't show up when it's time for education. We go there and we continue to go there. Once in a while, we just go and say, we are just here to check you to see how you're doing. And that's how we build the relationship with the community that we serve. Respecting the community's view, respecting what they feel, how they feel about their faith, their religion. We just have to continuously giving them the fact, acknowledging their needs. Sometimes you go there, you want to talk to them about hepatitis B, or you want to talk to them about chronic diseases. But at that particular time, what they need is a primary care physician. They don't have one, or they just don't have insurance. They need someone, or they just want somebody. They need somebody to talk to. So we sit down with them, we listen to them, and then we try as much as possible to validate what their fear is while we are providing them with facts. We communicate, continue to communicate and increase awareness. Meeting people where they are, that is a big deal. Sometimes you have an appointment with individual, you want to meet them, but remember now that this group of people or this community, they are the community that comes from somewhere all over the place. and everybody have their own needs. And then they have their own beliefs, they have their practices. They are very strong when it comes to their faith. And making sure that you are flexible, because in most cases, like the Africans say, African time, you give them 2 o'clock, they are not there till 3 o'clock or 4 o'clock. So you have to be flexible. And sometimes we do have to provide incentives, giving them things to make sure that we do appreciate their time. The incentive is nothing compared to the time that they are spending, it's nothing compared to the education that they are getting, but just to make sure that we do appreciate them, so we give out some incentives. Meeting basic needs and connecting them to resources. It is very hard. The resources in America, it is very hard. Sometimes it's just hard to navigate the system. Sometimes it's hard to just register yourself. Others just don't even know how to use the computer. For people that knows how to use the computer, they don't have the time to sit down there. So we have to help them with all that. And also be non-judgmental. If you are judgmental, you will lose them right away. They will go and they will not come back, So, and we want them to be back, because we want to make sure we eradicate these diseases, especially this hepatitis disease that we're talking about today. We want to eradicate it. So because of that, we are non-judgmental. We just give them facts. We sit down, we talk to them, and we just making sure that we are there when they need us. Also being consistent of what we're talking about, the education that we're giving them, because that is the only way they can also trust what is coming from us. And then following up with either the education that we do, or if we ask them to go and see the doctor, follow up with that. If we have make an appointment for them, follow up with that. If they need to be vaccinated, we follow up with that too. Next slide, please. Next slide, please. Now, on this slide, Mrs. Adedokun is going to present this slide. This slide is going to talk about the family that just had a baby, and this family, Mrs. Adedokun is going to talk about it, and this family, the mother has hepatitis B, and Mrs. Adedokun, you have the floor, please. Thank you all for listening.
Thank you so much. It's my honor. Thank you to the Hepatitis B Foundation for the great privilege. And thank you so much to Dr. Ogunnawo and Dr. Desu for the great and wonderful presentation. I would like to start from Actually, most of it all has already been said by my great doctors. So I would just have to add a little brief additions to it. And some of it is some misconceptions are patients from countries with high hepatitis B prevalence can wait until age 40 before getting screened. The truth is, any person from high prevalence region of the world, including the Asia Pacific, East Europe, India, and Africa, should be screened and vaccinated regardless of age. And some other misconception is hepatitis is an advanced liver disease caused by hepatitis A infection, and hepatitis B will develop and further advance to hepatitis B infection. Hepatitis A, B, C are diseases caused by 3 different and distinct viruses. Although each can cause similar symptoms, they have different modes of transmissions and distinct clinical manifestation. There is no progression from one form of infection to another. Although co-infection can occur, hepatitis C infected patients are recommended to be vaccinated for hepatitis A and B. And some of the misconception is, excuse me, please. If I got hepatitis A, I am immune to other form of hepatitis. It's hepatitis A, I'm sorry, one second, please. I have disconnection. I'm sorry for the break in transmission, please.
So maybe we can give just another minute for Mrs. Adedokan to rejoin, and if not, we can go ahead and, I know we have some questions to ask for these great presentations, so we'll just give another minute or so, and then see if we can ask some questions.
So I noticed some questions in the question and answer section. There's a question addressed to me that says, what are some of the ways that I would recommend to reduce religious or superstitions about hepatitis B? It's a good question. I have to admit, I think it's difficult to answer, but perhaps in my opinion, perhaps the most powerful tool we have is education. Education, right? If people are educated on what the virus is, how it's transmitted, the more you understand how it's transmitted, the more you will then be able to understand how it can be prevented by means of vaccination. And then when it's explained to you how it can be treated, then it's easier to understand that. And if you understand that whole spectrum of how it's transmitted, how it can be prevented, and how it can be treated, then it will start to chip away at some of the strongly entrenched religious and superstitious beliefs that have been built up from when people were born, right? They were born and they started to be exposed to these religious and superstitious beliefs. But we can chip away at that with education. That would be my response to that.
Doctor, can I chip into that, please?
Absolutely.
Yeah. I think that's a wonderful response. At the same token, one of the things that we found out is that if we know where they go to the church or the mosque, if you know who the pastor is or the imam, because the people listen to their faith leader more than the primary care physician. So in most cases, what we've been doing in the community, and I'm coming from the community view now, from the community, what we've been doing is to go to the pastor, talk to them, making them understand and increasing their education. And we believe that as long as they know exactly what it is, they are in a better position to explain to their congregation. And because the congregation believe in them and they trust them, and sometimes we have found out that the mosque or the mosque leader or the pastor, that they use the Bible or the Quran to also talk to them. They go to the verses where it is in the Quran or in the Bible that people have to take care of their health. So that is another thing that really helps too, coupled with the education and increasing the awareness and giving them the facts that you talk about. Thank you.
Yeah, I definitely agree with Dr. Diso the people that have influence over them, they can definitely help. And the fact is, religion doesn't support the idea of not seeking care. I'm a Christian myself, and as Dr. Diso was saying, God wants us to care for ourselves. So that's something religious leaders can tell members of the organization, and that should be have a good impact in overcoming those negative beliefs.
Now, let me tell you that I don't have an access to this screen, so I cannot see what the questions are. So I was thinking that the organizers would be reading the questions to us and we can go ahead and answer them. Thank you.
Yes, absolutely. So that was one of the first question that you both just addressed. So thank you so much. And the second question was about some impactful ways to address some of these misconceptions, which I think you both talked about a lot in terms of the importance of education and who's delivering the messages, especially faith leaders. And Dr. Disa, you had mentioned a lot about some of the creative outreach strategies that you're using in terms of going to salons and businesses and meeting community members where they are. So you've both provided so much really important information around that. So thank you so much. We did have a question about kind of data. And so this question is your state capturing and reporting data on hepatitis B within African communities, and specifically separating the data about African immigrants from African American, from data about African Americans, if y'all have insight to share about that.
I think Dr. will be able to answer that, but in my own view, I think that's one of the problems that we have. The problem is that the data is both African immigrants and Africans. And one of the problems is because of the stigma, it is very hard. I do applaud Doctor for the job that he did, the research, and I cannot imagine what he went through making sure that he got the participants for this research. Because of the stigma, because we do not believe as African immigrants, we do not believe in primary care. People feel that, you know, it's a waste of time when they need to talk about health. Because of that, it is hard with this population to have a whole lot of research. So I don't think that there is available research for that, but I think he can be able to address that. Doctor?
Yeah, I know that, for example, New York City Department of Health does a tremendous amount of data gathering. So I see that Nadine is on this meeting. There may be others, pharma. So at our CHIPO meeting and the quarterly meeting, oftentimes they present data. Now, as to whether it's disaggregated so that we know, you know, who are immigrants, and which various, because, you know, we can say African immigrants, but you know, are they from Nigeria, are they from Senegal, are they from Ghana or Togo and so forth? So to what extent the data is disaggregated, I do not know. I suspect that it's not as well disaggregated as we would like. But maybe some of the other members from New York, they can type a comment in the chat box if they have the information to that.
Yes, absolutely. Please do feel free. If anyone has more further thoughts on that, feel free to share in the chat. Another question that we had was, thank you so much for the presentations. I was wondering if you came across some cases where folks don't want to get screened because of the lack of resources available to them because of their immigration status. So how much immigration status can inform access to healthcare and prevention. If you guys want to share about that a little bit.
I can take part of that question because we do go through that when we're doing a lot of screening. Remember, in our organizations, one of the things we do is to screen, to educate and then screen for hepatitis. And the thing is that being an immigrant here is one of the problems. Another thing is when they need to be referred for treatment or they need to be referred for vaccine. But in Chicago here, in most cases, we do have, and I did mention that we have FQAC clinics where they can go, and in most cases, they probably have to pay $30. Sometimes we pay the $30, we use that as an incentive. We pay the $30 that we'll be charging them. And if they do go to the government clinic, they are not, they give it to them for free. They don't need to be charged at all. And then for the screening, sometimes we send them for screening. In most cases, we pay the organization that sponsor us or that give us the grant, they do pay for those screenings. So we let them know upfront that if they do go for screening, it's going to be taken care of. If they need to be treated, it will also be taken care of. And if they need to be vaccinated, it will be taken care of too. So that helps to increase those people that wanted to be screened and vaccinated.
That's great that that kind of support is available. Yeah, I know that that's a frequent issue that people are worried about using insurance and jeopardizing immigration status potentially. So that's great that that support is available. So I know we are approaching the top of the hour, so I want to thank you all so much for your incredible insights. And I think that this information was really valuable, and really thank you so much for participating, and thank you to everyone for coming. Shreya, if you could just pull up the last couple of slides, I just have a few concluding remarks. And thank you so much. So I just wanted to let everyone know about just some upcoming events that we have. So we have some more webinars like this. So we encourage you to mark your calendars for some of these. So some of you may know that the CDC recently announced that it is formally recommending that all adults in the United States be vaccinated against hepatitis B, which is a recommendation that has been decades in the making. So we're very excited that it's finally here. So we hope you can join us this upcoming Monday, April 25th at 3 p.m. Eastern for a webinar about these universal recommendations and some of their policy impacts. And then additionally, in about 2 weeks on Thursday, May 5th at 3 p.m. Eastern, the next in Happy United's webinar series will take place. And this will focus on the management of hepatitis B in pregnancy and postpartum, which is always a really important and timely topic. So the registration links for these webinars should be dropped in the chat. And then finally, so May is, as some of you may be aware, is an exciting month because it's Hepatitis Awareness Month in the United States. So the Hep Foundation, along with, I'm sure many of you on this call, will have a lot of events and activities going on, including on social media pages. So we encourage you, the Hep Foundation, to check us out and follow us on social media, Hep Foundation, Hep United, and CHIPO, and join in some of the campaigns that we have in May and beyond, as well as share what you're working on and get involved in our work. So you can, there's links to our social media in the chat as well. And then one final thing that we just wanted to mention is just make everyone aware of National African Immigrant and Refugee HIV and Hepatitis Awareness Day, or NIRA Day, which is annually celebrated on September 9th. And so just to kind of bring it up and make everyone aware of that this initiative is happening, and it's just a really great way to kind of continue to bring awareness to the issues of HIV and hepatitis in African immigrant communities as we continue, as they're not talked about enough. So we will likely have events going on around that, but just to make sure that that's on everyone's radars. And the website and social media links for NIRA Day will be available in the chat, and I'll also include it in the follow-up email that I send. So thank you. With all of that said, thank you so much again to our incredible speakers, Dr. Ogunwobi, Dr. Disu, and Mrs. Adedokan, and to everyone for participating in today's webinar. We really hope that you found it informative and valuable in your work, and that you can apply some of this information moving forward. We encourage you to complete our evaluation form at the conclusion of the webinar, and also please feel free to reach out and get in touch with us. Using our contact information on the slide, and you can reach out by email. And we thank you all so much again for attending, and hope you have a wonderful rest of the day. Take care. Bye.
Bye, everyone.